The other interesting thing that you need to do is that when you look at a cuff of any patient, you need to find out whether it's a crescent dominant shoulder or a cable dominant shoulder. The rotator cable is an extension of the coracohumeral ligament on the undersurface of the cuff. In elderly individuals, typically you get a cable dominant shoulder, in which case this cuff will relatively be resistant to cuff tear. So whenever a tear occurs, it will occur in the region of the crescent, but it won't be so much. So the biomechanical importance of the tear is not so much. Whereas in a crescent dominant shoulder, you don't have so much of thickening of the rotator cable. In such a case, any small tear can actually lead to more symptoms. This explains why some patients who have small tears have more symptoms and other ones who have large tears have less symptoms. You need to look for these black lines, the bursal surface and the articular surface black lines. They have to be present. If they are absent, then they imply that there is a tear. You can have some hyperintensity in the interstitium, the critical zone, but you typically should not see an absence of the black line. If you see this absence of the black line on the FSPD images, try to confirm it on the T2 weighted images. Like in this case, it's not a tear, just some degree of fraying. Whereas in this case, you can see that the bursal surface black line is intact. The articular surface black line is interrupted, so it's an articular surface partial tear. And you can see that on the FSPD images also. The other indirect ways of looking at cuff tears or trying to decide how important is it is to look for atrophy. That's a sagittal T1 weighted image, which is pretty important. That's a coracoid, so that's anterior, that's acromion, that's why that's posterior. The supraspinatus and the infraspinatus show quite a lot of fatty atrophy and reduction in bulk. If you draw a tangent on the superior surface, you see that the supraspinatus passes below the tangent, which implies that it's significant atrophy. There has to be a significant cuff tear. The other thing is that you might see a reasonably normal tendon, but if you see a scar tendinous junction, this can be the cause of the patient's symptoms, especially in young athletes. Like I mentioned, rotator cable, that's the anteroposterior continuation of CHL, or the coracohumeral ligament. On the sagittal image, you can see that that's the coracohumeral ligament passing over the biceps tendon. Then it's passing under the rotator cuff. And this is something which you should identify. If there's disruption of the rotator cable, that implies that the patient is going to be in more of trouble, and even small tears will lead to more problems. Not so new concept is that of a pasta lesion. That's a partial articular side supraspinatus tendon avulsion. This diagrammatic representation shows the laminae of supraspinatus. If you have a longitudinal and a transverse tear, there will be retraction of a lamina. Like in this case, that's the bursal surface lamina. That's the articular surface lamina. Because of a tear over here, this retracts and slides because there is another tear which is passing in over here. So this actually slides in as a lamina, and this is also important because here you get a retraction of the torn articular surface lamina. The other new concept is that of the infraspinatus footprint. Very commonly we see tears in regions which don't correspond to the normal supraspinatus footprint. If you see an axial section, that's the supraspinatus footprint, that's the infraspinatus footprint in a normal patient, and in an abnormal patient, that's a normal supraspinatus, and that's a torn infraspinatus in the anterior insertion. There's a very interesting paper in the JBJS by Mochizuki et al., in which they've actually done a dissection in trying to define what's the exact footprint. A normal classical teaching says that that's a large supraspinatus footprint and a large infraspinatus footprint. Whereas actually, the truth of it is that the supraspinatus has a very small footprint, partly on the lesser tuberosity. The majority of the greater tuberosity is taken up by the infraspinatus. Why that is important is that if you see a coronal image, most people will interpret this as a partial articular surface tear of the supraspinatus. However, if you see a coronal image in which you cannot see the AC joint and you triangulate it well, you'll actually realize that this is actually a partial articular surface tear of the infraspinatus, because that curls over the supraspinatus without forming any such thing as a conjoint tendon. Another concept which I mentioned is the rotator interval and the biceps pulley. This is a diagrammatic it's a drawing which shows the supraspinatus, the subscapularis, the transverse humeral ligament, and that's the biceps pulley. If you can see this better, that is the coracohumeral ligament, that's the superior glenohumeral ligament, and this is the biceps tendon. That white structure is actually the representation of the rotator cable. And typically, if there is any pathology in the biceps pulley, it's easy to understand that the biceps then has a more oblique course and there is an abnormal biomechanics. So a normal biceps pulley, this is again a diagrammatic on a sagittal image which shows the lesser tuberosity as a flat surface. That's the humeral head. That's the biceps pulley, and that's the biceps. The pulley is formed by the coracohumeral ligament on top and by the superior glenohumeral ligament medially. On a sagittal MR, again, that's the coracoid, that's the humeral head, that's the lesser tuberosity. Biceps tendon, that's the pulley which is formed by the CHL, and that's the superior glenohumeral ligament. If there is tear of the pulley, there is sag or there is displacement of the biceps tendon, which leads to early tendinosis. This is what is known as a hidden lesion. This is only one case in all my experience up till now, in which there is an isolated tear of the biceps pulley, and there is displacement of the biceps tendon out of the pulley, which has been proved by arthroscopy also. This is something which, unless you mention it, the arthroscopist might not look for it, and the patient will have pain and will have continuous tendinosis and tear of the biceps tendon thereafter. The most common lesion is actually a biceps pulley sag. Normally the biceps tendon lies above the level of the lesser tuberosity, which is this flattened area over here. If you see sag of the tendon, of the pulley and the tendon coming over the lesser tuberosity, this is also pathological. This usually occurs in the setting of subscapularis or anterior third supraspinatus tears. Finally, coming to frozen shoulder, typically you can see it, these are sagittal T1 weighted images. You need to look for the coracohumeral ligament thickening. You need to see for effacement of the subcoracoid fat triangle. You need to look for thickening of the inferior glenohumeral ligament on the coronal and on the sagittal images. And finally, you might see thickening of the biceps pulley. All of these are signs of frozen shoulder. They're easily evaluated on MR. In glenohumeral instability, coming to the next topic, you look at the topmost sections on the axial images. You look for flattening of the posterosupralateral aspect of the humeral head. And you can see that on the sagittal images also. You look at the inferior-most images to look for the Bankart's lesion, and you try to look for the sagittal images to try to see how much of the volume of the glenoid is actually broken in the Bankart's lesion. On the axial images, you have to see the first three axial images. They normally should be a spherical image. If you see flattening, that's an early sign of a Hill-Sachs lesion. On the axial images, the other thing which you need to find out is what is the sagittal level at which the Bankart-like lesion is seen. If it is seen below the level of the equator of the glenoid, that means below this level, if you see this is a normal indentation, if it's below this level between 3 and 6 o'clock, that's a classical Bankart's lesion. Whereas if it's around 3 o'clock, like it is in this case, that's a micro-instability lesion, which can lead to symptoms. Again, this is showing the same thing. That's the equator of the glenoid. If you see a tear which is below the level of the equator of the glenoid, that's a Bankart's lesion. Ending up with three interesting cases. These are actual FSPD images of a bowler who presented with pain in his shoulder. If you look very carefully, you can see that there is this hypointensity in the posterior aspect of the glenoid that corresponds to what is known as a Bennett lesion. This is an interesting case because here you see that's the rotator cable. There appears to be a tear over here, and this could be either an avulsion of the greater tuberosity, but it's not, you can't see any cortical fragment. On the actual medic image, you can actually see that this appears to be an area of calcification. That's calcific tendinitis with tear. And lastly, this is a case in which the cuff itself is intact. You can see a hypointense structure which is dissecting into the myotendinous junction, which shows blooming on the medic images. That's hydroxyapatite deposition disease dissecting into the cuff. Thank you.